Good morning, good afternoon, and good evening, depending on wherever you are. Welcome to our session, special session, COVID-19 session number 48. This is the 48th session of our special series, which we have dedicated to diagnostics in the COVID-19 era. Today's session is not only just a special COVID-19 session, but it is also special in the sense that we are also hosting it from the beautiful kingdom of Eswatini. With me here, I have colleagues from Eswatini, and my colleague here, Michael Waweru Waina, the M&D specialist from ASLM. I also have next to her the Chief Medical Laboratory Technologist of the Eswatini Health Laboratory Services, Mage Asindisiwe Dlamini. I also have Mr. Fulton Nzinisa, who is the Principal Laboratory Technologist also at the Eswatini Health Laboratory Services. And last but not least, I have Mr. Tafuma Zanamwe, who is the IT Specialist at the ICAP Columbia in Eswatini. So a special day indeed. Today's topic, we are looking at how far we have gone with regards to that. Yeah. How far? Okay, I can hear Sarah on the French channel. I don't know whether it's the same. Yeah. Yes, so those that would like to tune in to the French channel, it's available. Make sure you choose either French or English so that there is no crossover of the languages. This will be a 1 hour long session that will start with a presentation and will follow with a question and answer segment. To take us through the special session today, we have a presenter who needs no introduction, and in the name of Professor Rosanna Pilling. Professor Pilling is the director at the International Diagnostic Center. She's a chair and professor of research and director at the International Diagnostic Center for the London School of Hygiene and Tropical Medicine. Prof. Pilling, I would like to hand over to you to take us through today's session. Thank you.
Thank you very much, Anavi, and it's a pleasure for me to be speaking today. Thank you for ASLM for inviting me. So let me share my screen. So diagnostics is usually undervalued in global health. So what I'm going to do over the next 35 minutes or so is to talk about the value of diagnostics in epidemic preparedness and response, and how some of the special features of SARS-CoV-2 in fact are relevant to how we use diagnostics in this pandemic. And then how the use of diagnostics changes over time as the year has unfolded and we know more about the virus and its modes of transmission. So this is the dashboard from WHO as of the 7th of September. There's been over 200 million confirmed cases around the world, with about 4.5 million deaths reported to WHO. And of course, we know the truth is higher than that, because those are only the official reporting rates. Now, we are still looking at daily rates of over 300,000 a day. And so I think that the pandemic is far from over, but the good news is that the vaccines are being rolled out. Now, from the very beginning of the pandemic, the Director General of WHO already urged countries to test, test, and test. He said that testing, isolation, and contact tracing should be the backbone of the global pandemic response. Now, for any infectious disease of epidemic potential, diagnostics play a really critical role in patient management to confirm clinical diagnosis in symptomatic patients, to enable the patient to get the appropriate care, including the appropriate treatment, if one's available, and then to inform the patients of measures such as isolation to stop the spread of infection. Now, on a population basis, testing allows the cases to be detected so that you could do contact tracing and screening of those who are at enhanced risk of acquiring and transmitting infection, such as healthcare workers in SARS coronavirus 2, the care of patients in care homes. And then you could also use the case rates to map the locations and to track the pattern of transmission and to identify hotspots. And finally, to enable implementations of to guide control strategies such as when to impose mask mandates, quarantines, lockdowns, and border measures. Now, there are three major types of diagnostics that are being used in terms of SARS coronavirus 2. And they are laboratory-based molecular tests, such as PCR, that is used to detect viral RNA. And the optimal time for use of that is about, time from the onset of symptoms to about in the first 7 days, when the period of viral shedding is highest. And that's to confirm a clinical suspicion of those who are symptomatic. There are also antigen tests, both lab-based and point-of-care tests that are used to detect viral proteins. Again, the optimal time to use is right after a person is symptomatic. And that goes for most infectious diseases. And then there are serology tests, which are not used to detect the virus itself, but to detect host markers, such as IgM and IgG or IgA antibodies. And those are typically used at least 7, if not 14 days after onset of symptoms, because that's when the immune response kicks in. And they are used as a marker of exposure and for surveillance. Now, with all three tests, we need to think about the accuracy. Molecular tests are the most accurate in terms of sensitivity and specificity, but it comes with the cost, the high cost, as well as being technically complex, so you need trained personnel to use it, versus antigen tests, especially the point-of-care antigen tests, which can be disposable single-use rapid tests, which are a lot more accessible in that they could be used outside of lab settings, in most settings in the community with minimal training, and they are lower in cost. And usually the rapid test for antibody detection is the cheapest, as we've seen with HIV rapid tests, that they are about between 50 cents to $1, versus for coronavirus, antigen tests are between $2.50 to about $8, whereas molecular tests are about $15. And so in choosing the right test for the right patient at the right time in the right setting, we need to think about the balance of the 3 A's of accuracy, accessibility, and affordability. Now, how has the pandemic unfolded so that we need to not have one single testing strategy, but have it evolve over time? If we look at the beginning of the pandemic, when the pathogen was first identified and the genome was sequenced, then diagnostics had been developed to allow us to be able to refine the case definition in terms of the symptoms of people presenting with fever, cough, and also shortness of breath. And those were the three symptoms that were at the beginning. But since then, we've now used diagnostics to be able to refine that case definition, and actually found that loss of sense of smell and other conditions are associated with COVID-19. And in the beginning, diagnostic tests are used to detect, to test all symptomatic individuals regardless of their status, to try to enable public health measures such as isolation to be implemented if they test positive, to determine the extent and the speed of transmission, and to be able to conduct studies to understand the modes of transmission. And also testing of confirmed cases as well as their contacts are really important to be able to interrupt the chain of transmission as they go into isolation. But several months into the pandemic, we realized from contact tracing studies that asymptomatic individuals as well as pre-symptomatic individuals are also able to transmit the infection. And by pre-symptomatic individuals, we mean that when they were tested, they may not have any symptoms, but subsequently they develop symptoms after testing. And so with that, we realized we need to scale up testing in the communities to ensure that we have every means of tracing down all the cases and stop their spread by asking those individuals to self-isolate, and also making sure that populations at enhanced risk of acquisition and transmission of the virus to be tested, so that they would not be transmitting the infection, especially to those who are vulnerable, such as those who are sick and in hospital or in care homes. And countries started to test for travel. And then there are certain occupational groups that are in non-healthcare settings that are associated with outbreaks. And so those need to be tested. But scaling up is not easy to do. So I'll go a little bit into that later. And now with the variants of concern that has emerged first around the end of last year, and now with both from the alpha, beta, gamma, and then delta variants, we now need to be a lot more dependent on surveillance to try to track these variants of concern. And as vaccination rates start to climb, we hope that although demand of testing for symptomatic individuals and contacts are still going to be used, but they may be now less important compared to surveillance if the vaccination rates are high. But nevertheless, we still need to be using tests to try to allow the economy to recover, and for schools, workplaces to reopen, and mass gatherings to take place. So what are some of the special features of COVID-19 that makes us use tests that are unusual for an infectious disease? First of all, we found out, as I said, that infected individuals can actually shed before they become symptomatic. So we cannot use symptom alone as an indicator of the indicator for testing, and that this silent spread of infection in asymptomatic individuals makes it really hard to try to find all the cases to stop the pandemic. We know from culture studies that infectivity could be anywhere from 8 to 9 days post onset of symptoms. and that most of the time, by day 7, post onset of symptoms, we can see detectable levels of IgM and IgG antibodies, which is very unusual. And then we also found out that because RNA tests are very sensitive, a person can remain RNA positives for weeks after onset of symptoms, and when they're in fact no longer infectious. Now, here's a systematic review that was conducted by the Irish Health Information and Quality Authority to show that in fact, the onset of the antibody responses are very early, and with a maturation around 11 or 12 to 14 days after onset of symptoms. So you could see for IgM, between all the different studies, between 10% to 70% of individuals already have detectable levels of IgM within the first week of after onset of symptoms, and the same for IgG, although a little bit less. And with that, in China, they actually use antibody tests as well as RNA tests to try to maximize the case detection rate. And so you could see here that in the first 7 days post onset of symptoms, if you use RNA alone, you could detect about 67% of the cases, but already 38% are antibody positive. And I must say that, you need to use an antibody test that is very specific. Otherwise, it would be a false positive. And so together with RNA and antibody, you could see that within the first week, you could detect about 79% of the cases versus 67, and that by week 2, you could detect almost all the cases. And so that's an unusual use of antibodies. And in fact, with the global competition for PCR reagents, some countries did resort to using antibodies when they ran out of PCR reagents. Now, another thing that we still don't know is the correlate of protection. And here we see in this study conducted in Hong Kong that in both COVID patients with mild cases or severe cases, antibodies against the nucleic acid protein, NP, or the receptor binding domain, RBD, of the spike protein are shown in these patients very early on in their disease course. And yet at the same time, you could isolate virus from these individuals, from both the saliva and the endotracheal aspirate. So we don't really know the correlate of protection yet, because these the nucleic acid protein and the spike protein are supposed to be the targets of neutralizing antibodies. And yet we see that you could have both virus still present as well as antibody. So even today, we still don't really know the correlates of protection, even though we know that the spike protein, especially the receptor binding domain, should be the main target of protective immune response. So what are the changes in the diagnostics in the course of the pandemic? So first of all, WHO has recommended for patient with COVID-like symptoms, regardless of whether they've been vaccinated or not. And a molecular test should be used to determine whether they have COVID-19 or not. So if they are positive, it means that they are confirmed to have the virus. But if they are symptomatic but test negative by the molecular test, especially if there's high index of suspicion from other clinical presentations such as X-rays, then the molecular test should be repeated. And if the repeat test is positive, then they are confirmed as a case and should go into isolation and all the preventive measures. If they test negative, though, some countries choose to do an antibody test, although that's not part of the WHO recommendation. And for most countries, even if you test negative, but you're symptomatic, you should continue to adhere to public health measures. Now, challenges with PCR testing is that as I mentioned, the cost is high. You require a lab and expensive equipment. You require trained personnel. And for most countries, because they don't have enough PCR capacity to test everyone who presents with COVID-like symptoms, sometimes the delay could be hours, but others, it could be days or weeks. And also, this is compounded by the global competition for reagents. And lots of countries are left with very limited supplies. Now, there are point-of-care tests that can be used, and they are also very highly accurate, but they are limited by the speed of the manufacturing of both the small machines for point-of-care testing outside of the lab, as well as the cartridges. And so companies have started to develop antigen tests, and these are the early antigen tests that are used with a small instrument for reading. And so they're essentially like the lateral flow test, but they are being read on a machine to increase the sensitivity. And most of these only require about 15 to 30 minutes to get a positive result. And from what is shown here is company data. And these are FDA approved early in the pandemic. Now, WHO has recommended that antigen tests should have at least a sensitivity of 80% compared to PCR and a specificity of 97%. And these tests all fulfill that criteria. And they could be used for symptomatic individuals to begin with. And in some countries, they are allowed to use them for asymptomatic individuals, but those at asymptomatic individuals at high risk of COVID-19. And the specimen that is used are nasal swabs or nasopharyngeal swabs. So the diagnostic algorithm in the WHO recommendation is that in patients with COVID-like symptoms, if PCR is not available or that PCR is delayed, by all means use the antigen test. If it's positive, because of the high pre-test likelihood, the test does not need confirmation. And so any positive tests should be treated as a COVID case. Now, if the antigen test is negative, it's maybe because of the low sensitivity of antigen tests compared to the PCR test. And so you should confirm the negative test by using a second molecular using a second antigen test or a molecular test. And if the person is positive, they should be treated as a case. Now, if they're negative, it probably means that they have no evidence of COVID. But because they're symptomatic, they should continue to adhere to public health measures. So now, with the second phase of the epidemic, when we know that there are a lot of asymptomatic spread, and some studies shown that the asymptomatic spread could be as high as 40% of the transmission, then we need to be scaling up testing. And so how could we do that? Now, in terms of policies, different countries have decided on different policies. Now, for clinical management of patients, symptomatic patients, that's very clear. You use molecular tests, either lab-based or the rapid test, or the rapid antigen tests where molecular tests are not available or delayed. But how do you do the community-based testing to look for all the asymptomatic individuals who are spreading the infection and look at spreading the silent epidemic that is going on in communities? The question would be, what's the coverage? How frequently should you be doing the testing, screening for infection in asymptomatic individuals? Who is it that you should target if mass testing is not feasible because of the limited supply of tests, as well as limited number of people who could do the testing, and then what tests and where. Those are all the policy decisions that each country has to decide to make. Now, there are single-use disposable tests that were quickly developed, and here I'm showing you 3 tests that have received WHO emergency use authorization listing, and that's in the section in pink. And in green are some of the tests that the FDA, the US FDA has approved for emergency use for this pandemic. There are quite a number of them. The ones that I selected to show here are ones that also make home tests or self-tests. And you could see from the performance that a lot of them do perform very well. The WHO pre-quad, WHO emergency use authorized tests, the performance were from the FIND website, the Foundation for Innovative New Diagnostics, that are doing evaluations on behalf of WHO. But the FDA site just shows the performance data from the companies. The FIND evaluation also look at the lower limit of detection for antigen tests. And you could see that most of them are around about 1 million tests, about a million virus copies per mil of sample, compared to about between 100 to 1,000 copies that could be detected by RNA. So the time to result is very quick, but we do have a difference in the sensitivity, but they are now cheaper than the molecular tests, and also the instrument-based antigen tests. And you will see in the literature a variation in the performance based on what standard was used for the molecular testing as a gold standard, and the viral load of the specimens used in the evaluation panel. But what's important to note is that if you look in the pink section, under the sensitivity, that they show in the FIND website a cycle threshold CT value. And the cycle threshold is the number of times that the amplification cycle has to be performed in order to get a positive test. So the smaller number means that it's higher viral load. So you could see that for a CT value of less than 25 for PCR, antigen tests can detect those with almost 100%. So that means that antigen test is more like a test of infectiousness or infectivity. And so that's useful in terms of using it for screening for infections. Now, as to how often you screen and what test do you use? As you remember, I said you need to balance between the 3 A's of accuracy, accessibility, which is ease of use, and also the affordability. How often can you screen? And also in this model that's published by Michael Miner's group at Harvard, they show that test sensitivity is in fact secondary to the frequency of screening and the turnaround time for results. And so with each one of the round dots around that in that table shows a point of screening. And so you could see that with antigen tests, although it has lower analytical sensitivity, because you could afford to screen more often, you are more likely to hit upon a time when a person is in their period of viremia versus the one that shows higher analytical sensitivity, PCR, but less frequent screening. So because it's less frequent, you may risk detecting a person during their period of infectiousness. And so those are the things to keep in mind as you try to look at what test to use and when to use it. Now, Africa CDC has published in December of last year interim guidance on the use of rapid antigen tests for the COVID-19 response. But it's not to say that everybody should abandon PCR and use the antigen test. And so in the guidance, Africa CDC very clearly urged countries to establish very clear roles for both COVID-19 antigen rapid test testing and also real-time PCR within the new testing strategy, and not have one to replace the other, because we need to be using all the tests that we have in our portfolio to be able to end this pandemic. And with antigen tests, because we're trying to use it in healthcare as well as non-healthcare settings, it's really important to countries need to have support systems to do comprehensive training and supervision. Supply chain management is now very important as you ramp up testing, and then quality assurance. And at this point, I like to say that I was really pleased to be there for the ASLM launch of their e-learning platform for training on how to use antigen rapid tests earlier this week. And because it's free, it's truly accessible by anybody who has internet, and it really would maximize the use of these antigen tests with high quality and making sure the results are correct. And then also how the data is captured to inform evidence-based decisions, not only for the patient, but for the population, is really important. And then the CDC, Africa CDC urged countries to continuously update their testing strategies based on information gained domestically as well as across Africa. So in terms of the recommendations, here is an algorithm taken from the Africa CDC recommendation for symptomatic cases and frontline healthcare workers, essential workers, contacts of confirmed cases, and any high-risk populations in confirmed outbreaks. And so these are people at high likelihood of being positive. And so if you have an antigen positive result, it should be managed as a positive without having to resort to any confirmation. But if you're antigen negative and you have a high degree of suspicion that the person could be positive, then isolate and manage as a positive result if the confirmation molecular test or antigen test is positive. But if it's negative, then you try to work up the cause of the symptoms, and in the meantime, manage as a negative result. But on the other hand, for general population screening, Africa CDC recommends the use of the antigen test. When it's positive, you need to confirm, because of the low pretest likelihood of a person testing positive in the general population. We may encounter more false positives than real positives. So it's really important to confirm any positive result. So you could see here the confirmation is required for a negative result when you have symptomatic cases or people at high likelihood of testing positive. But when you have people who are at low likelihood of testing positive, such as general population screening, it's important to confirm antigen positive result in order to get rid of false positives. So these are really important concepts to remember for the use of the antigen test. And so how do countries use it? I give you the Cameroon in terms of their use. They decided they would track, test, and treat to control the spread of SARS by maximizing case detection, but also at the same time try to limit the mortality due to COVID with correct patient management, but limit the social economic impact of COVID-19 by continuing with activities and community engagement. And so here's the flowchart for the national algorithm for COVID testing. And this is thanks to Yap Boom from Cameroon, who shared this with us in an earlier webinar organized by the IDC and our Global Health CPD webinar series. And so they chose to use rapid antigen tests. And if it's positive, confirm as a case. If it's negative, and if the person is symptomatic, use PCR to see whether the person is in fact a COVID case. And if the person is asymptomatic, then it's considered not a case. And because they use rapid antigen tests, the test can be done anywhere. And here you could see that they are being done in markets. And so overall, this is some time ago now, 80,000 cases were reported in Cameroon, with 60% detected with antigen tests. And so in terms of thinking about a broader framework for policy consultations, especially when you have to do testing in non-healthcare settings in order to allow economic recovery and save livelihoods, it really is important for the policy to be science-based, to be very inclusive of those populations for which the testing is adhered to, which means a consultation with ministries of education, with civil societies, Ministry of Finance, Trade and Tourism, and border authorities. And everything needs to be context specific, and you need to think about resources available, and you need to be agile, because now we have variants of concern that are more transmissible, but we also have vaccination that could give the population some degree of immunity. And all this has to be conveyed in a very clear, compelling message to the public. Now, one example is the test drivers truck drivers in Kenya. So in May of last year, the truck drivers were told that they need to be tested before they could drive to in Kenya and to another country, and so. At Mombasa, where a lot of goods come into Mombasa, and they are destined for Uganda, Rwanda, Burundi, DRC, and South Sudan, they're all stuck at the port of Mombasa because the truck drivers were waiting up to 2 weeks to get their PCR results in order to leave the port. And so the solution is that the International Organization for Migration, IOM, provided some rapid PCR tests to the truck drivers in the port of Mombasa, and to allow them to be able to get their test results within 24 to 36 hours. And with that, ease the congestion at the port. And here's an example of a workplace screening. Early in the pandemic, meat processing plants were frequently the site of outbreaks because of the air being recirculated in rooms that are refrigerated. So here in Ireland, they actually modeled how frequently they should be screening their workers. And in the end, with the modeling and resources available, they decided rather than doing PCR screening once a month, they would do twice a week when the community prevalence is high, and then it could be scaled down to once a week if it's lower. And here it shows you how they do the screening before they are allowed to come into work. And it's actually self-sampling, and it's a supervised self-sampling. And then the test is done by trained workers. And this has worked very well for the meat processing plants. I'll show you some quick examples of mass gathering in football final in Qatar, where 20,000 people attended an outdoor event. But you could see here that testing is only a package of a lot of different interventions, including temperature checks, wearing of masks, and also distancing, such as having every other seat remain empty and people needed to be tested before entry. And there's also a randomized control trial that was done in Barcelona for a music event where people are actually allowed to dance and sing, but they, again, testing is part of a whole lot of preventive measures such as temperature checks, mask mandate, testing on the day before entry. And then they were given N95 masks, but they don't have to have distancing, and they could dance, sing, and as they wanted. And there were no transmission after the event. Now with variants of concern, and we know that many of these variants are now more transmissible than before, and is spreading widely across Africa and other countries. What should we do? Now, because almost all the antigen tests are based on the nucleic acid protein as a target, and the variants of concern that we are concerned about are mainly on the spike protein. So antigen tests are not affected by the variants of concern, but some of the PCR tests may be affected. Now, for travel, this is a model that was done by a group, Alex Cook's group in Singapore, modeling the effectiveness of both pre-boarding screening as well as what happens on landing. And this became important as variants of concern are circulating in different countries to make sure that on arrival, people are not positive. And so if you see the reduction in case rates relative to having no controls on landing, if you quarantine for 7 days, the effect in terms of reduction in case rates is about 55%. If you test on arrival and denied entry, then it's 77%. But if you do a combination of testing on arrival and then quarantine for 7 days with testing, then it's effective up to about 90% reduction, or it could be quarantine for 14 days without any testing, or a combination of both. And so you could see that testing has become, on arrival, has become part of border measures for a lot of countries, along with quarantine. So now, in the last phase, right now, in some countries where vaccine is being rolled out, again, testing of symptomatic patients and contact tracing remain very important, and screening of high-risk individuals are important. But more now emphasis is being paid on surveillance, and countries are starting to look at antibodies tests for surveillance, as well as using PCR tests for symptomatic patients and contacts, and antigen testing for both screening of high-risk individuals as well as in non-healthcare settings. And so we now have these tests being used as both a diagnostic tool and as a public health tool to test to protect vulnerable patients, populations, test to release from quarantine, test to enable the reopening of schools. So it's unlike the use of testing as a diagnostic tool. And then now we have home testing, where people in the US now, you could buy them over the counter, $20 for a package of, I think, 6 tests or 4 tests. And so testing is widely available in all different forms. And we need to think about whether it's possible to remove the quarantine period. So this is a model that was done by the modelers from the school to say that if you do testing on arrival for 5 days, testing every day by antigen tests, you could reduce a case importation risk by 91%. Whereas if you do PCR testing every day for 5 days after arrival, then you could reduce the rates to 95% importation risk. And so this is really important in able to allow economic recovery, because quarantine is still a major deterrent for businesses to resume travel to other countries. And also in Africa, we need to look forward to the time when the Africa Cup of Nations is being sponsored in Cameroon, and how we need to use every test we have at our disposal to try to organize these major gatherings. And I'd like to end by saying that there's been a couple of papers published on the perspective of the future of the COVID-19. And there are many key gaps in developing an effective global response that we've learned over the last year and a half. But amongst tools and technologies, I'd like to highlight that these authors identify that globally accessible diagnostics and deep sequencing tools to establish continuous and sustained global surveillance of disease and variants are really important in having an effective global response. And in Africa, in fact, the Pathogen Genomics Institute that was set up by Africa CDC has been doing a lot of sequencing from many different countries with sequencing centers that are being set up around the continent. And to date has, sequenced more than, I think, 40,000 isolates from around Africa. So in fact, Africa is well prepared for tracking the variants of concern, as well as to know what is happening across. So in summary, I like to say that we need to use all the diagnostic tests available, but making sure that we use them in the right way to guide patient management, as well as to enable to protect the public, to release from quarantine, to enable economic recovery and the reopening of schools and workplaces. And the choice of tests of when to use where and how often, that has to be decided by each country, balancing the risks and benefits of test accuracy, accessibility, affordability, and time to result. And as we now learn to live with the virus, testing for surveillance becomes very important, along with genomic sequencing. So thank you very much for listening. And I'd like to end here for any questions. Thank you.
Thank you very much, Rosanna, it's a wonderful presentation. I couldn't stop checking every slide. I think many important points that you raised through there. So it's time where we need to take questions and comments, keep them coming through into the chat box. There's one thing that really strikes me particularly, which is coming from the summary here. We are almost 24 months into the pandemic. And I think I like the point that you mentioned, that I think all these diagnostics at our disposals are not there to replace one another, but they are there to complement each other. Also, like the slide where you show the utility of testing using antigen testing and the ability to somehow detect possible infection through the life cycle of potential infection. So I think let me take questions from the chat, keep them coming. I think one of the earlier questions that came through was a little bit vague, but I think you touched on this where you said mostly we are sort of concerned in testing those that are symptomatic, but what is the utility of also testing for asymptomatic patients? I think there was a slide that you presented on the several diagnostic tests that are available. Maybe just to start by emphasizing what needs to be used for both symptomatic or asymptomatic patients.
Should I go back to the slide for with Africa CDC's recommendation?
Yes, that's important.
Sorry. No, so this is the WHO one. So yeah, this one. Yeah. So it's really important because we know that there's a silent epidemic going on underneath the surface of all the people who are symptomatic. There's a whole lot of asymptomatic or pre-symptomatic people who could also be harboring infections that we don't know of. And depending on what they do, if they are constantly in contact with the public, they may be inadvertently spreading the infection to people that they care for, if they're healthcare workers, especially if they work in care homes for the elderly, they will be passing the infection to vulnerable people. So it's really important to screen for infections in those with enhanced risk. And I mentioned the truck driver example. Kenya recognized very early that truck drivers, if they're positive, they will be spreading the infection wherever they drive to, from country to country or within the same country. So for those occupational groups, it's really important to be screening, but it's how often you screen, right? And those usually the frequency of screening is based on how high the case rates are in the community. And it's similar in screening for schools. The CDC has put out very good guidance on screening of teachers and students in schools, and it's based on how high the COVID rates are in the community. They don't recommend screening unless the rates are very high. They usually recommend as a first mandate wearing of masks as well as distancing and frequent hand washing. So.
Thank you very much, Rosanna, for clarifying that. I think picking up on that element of screening, there is this message. It came from Vasundara, I think he's from India. He gives his perspectives from India, where he says the rapid antigen test, I assume RIT, that's what it means, being used all over India and many other parts of the world, is said to have a sensitivity of around 50%. I think it touches on that slide of sensitivity, although WHO recommendations have higher sensitivity. So he says a negative test could be confirmed by PCR again, and that this brings an issue of access, infrastructure. So the whole point of reaching that last mile is lost. He says, what do you think about this? And what is the role could there be a role of a second antigen test for recommended first negative? Is that a repeat or another type of antigen test required? So it brings in some operational issues now, particularly looking at the performance of the tests.
Yes, I think there's a lot of confusion about the performance of antigen tests. And as I mentioned in the slide with the different, let me go back to this one. I mentioned that the performance of these tests will vary depending on the kind of reference standard that you use. Remember, not all PCR are the same, and so depending on what PCR standard or other molecular tests that you use, the performance could be different. And also, what is mostly responsible for the difference is the viral load of the samples that you use for the evaluation. So if you use a lot of samples from people in hospital with high viral load, then the test performs very well. But if you use people in outside of the health sectors and maybe their viral load is not very high, then the performance of the test would not be very good. So even if you go to the FIND website, and I give here the link to the FIND website, you would see that for the both the Abbott and the biosensor tests, FIND actually evaluate these tests in both Germany, a reference lab in Germany, as well as in Switzerland, and in some cases, a lab in Brazil. And the performance are all different because the panel that they use for evaluation is not standardized to be exactly the same. It varies in terms of the viral load. And so you will get different performance. But in general, most of these tests should be, you should be concerned about the lower limit of detection. As long as they could detect between 10 to the 5 to 10 to the 6 virus per viral copy per mil, they will pick up active infections, because we know from culture studies that people do not remain infectious beyond the first 8 days of post-onset of symptoms. And the threshold for that is around about 1 million tests. So anybody with less than 1 million tests, 1 million viral load per copy, per mil of sample is unlikely to transmit the infection. And so antigen tests are very useful as a test of picking up anybody who's infectious. And so hopefully there will be a standard panel that could be used to evaluate all the tests, and we won't have that confusion.
Thank you, Rosanna, for the elaborate response. Indeed, they are useful. You showed various settings where antigen tests have been used to improve the ability to screen this. One of the operational problems that has been, I think, is a comment in the chat. One of the operational problems with antigen assays is the maybe challenges when it comes to result reporting and follow-up. Hence, this can be an issue for confirming cases. What is your recommendation to scale up RRGTs whilst results are being used appropriately?
So I think that many of the companies have now ways that you could use either a phone to, you download an app and use your phone to read the result, and the result could be then transmitted to whoever you want, or that you could carry it on your phone as a QR code to indicate that you have a negative test that you could use then for travel and for other purposes where you need to show that you're negative. And so, but I think that there's a lot of variation in different countries as to how the data for rapid antigen testing is being used. We know from rolling out rapid tests for malaria, for HIV, and for other diseases that it's very hard to capture all the data in real time to be able to get a timely guidance on testing strategies. And that's something that countries need to really work at. And so that we, the daily dashboards that you could see, and we're used to seeing that now, it truly reflects what's on the ground. And so a lot of those logistics and data management has to be worked out. And that's something that Africa CDC, if you remember in my presentation, that Africa CDC, in fact, urged countries to pay attention to data management for use of these rapid tests.
Thank you very much once again, Prof, for that. I know it's at the top of the hour. If you allow me to add one or two more questions, quite a lot of important questions in the chat.
Yeah, okay.
Yeah, one interesting one that I see there is, I think you touched on this, and it's a common question that comes around emerging variants of concern. And maybe if you could re-clarify what is it with diagnostics? I think you talked about the nucleocapsid protein and the ability to pick these.
Yeah, so in terms of variants of concern and how it affects testing, there are websites that you could use. You could go to the PATH website, the Program for Appropriate Technology in Health, has put up a website where they show different tests and whether they are affected by the different variants of concern. And the US FDA has also put out an advisory for 4 different molecular tests whose performance is likely affected by variants of concern because the target is on the spike protein, and possibly the mutations in the spike protein that are responsible for these variants are within the target of the diagnostic assay. And so, as I mentioned, though, for antigen tests, we don't really need to worry, because as far as I know, there's only one antigen test that uses the spike protein as a target. All the other tests use the nucleocapsid protein, which is not, the mutations do not affect that protein. And so antigen tests are not affected by these variants. But for molecular tests, you have to be very careful. And in fact, one of the companies whose PCR test has been affected by the variant is actually using that test as a test of detection for the variant, which is very useful.
Useful indeed. Thank you very much. We have a lot of questions, Prof, so that we will ask that we send them to you, and maybe if we can then send to the participants in writing. But yes. One last one. I also want to acknowledge, I think, all those that have put questions into the chat, all the interaction that is happening in the chat. Margarite also, thanks as well as Basu for the exchanges in there. One last time that I would like to really pause would be, I think we have been talking about a limited number of sample types. So the question here, what are the perspectives of alternative sample types for sampling? Maybe if we are now looking at sampling in children, and also increase acceptability of testing, particularly for community surveillance.
Yes, that's a really, really good question and very relevant. I'm sorry I didn't have time to go into that, but there has been systematic reviews that show that saliva testing, and we're not talking about just simple spitting out the saliva. We're talking about a process where you try to get saliva deep from the back of your throat. because that's where the virus is likely situated. But a systematic review showed that saliva testing is not as sensitive as a nasal swab or a nasopharyngeal swab. Nasopharyngeal swabs are about equivalent in terms of the amount of virus that you could extract, although, if you're going to do self-sampling or if you're going to do a lot of community-based sampling, much easier to do a nasal swab, which is just going through 5 times the nasal cavity without going very deep into the nasopharyngeal region. And so those are some of the choices that have to be made. I think for it's similar to choice of tests. The choice of samples also depends on the ease of use, right? And balancing that with the sample yield that you have. And so I would say that for community-based testing, swabbing the nose is the easiest and has the most yield versus doing a saliva test. Although saliva testing, if you use PCR, I think it's likely that you would be able to detect any case of anybody who's positive.
Yeah, thank you very much. Interesting perspectives indeed. And I think maybe to extend there, personally, I think when you also look at TB and potential of those samples that come deep, maybe the sputum and everything like that, maybe it would make that bi-directional testing also quite possible. Prof, within a minute or two, maybe just, I know there's a lot of important information, maybe just crystallize that in about 30 seconds. What would be your parting word?
My parting word would be that we're at a fantastic situation with over 1,000 different diagnostic tests at our disposal. We need to be using all the tests that we have to the best of our ability, choosing the right tests at the right time, in the right place to maximize our results so that together we could end this pandemic.
Thank you, Prof, for crystallizing that for us. Colleagues, unfortunately, everything comes to an end and we would like to end this session now. But before that, many thanks to Prof for coming through with the wealth of knowledge. Many thanks to all of you who attended. Many thanks to all of you who took part in the discussions in the chat. As promised, we will work with Prof to try and answer some of the key questions that you left in the chat box there. I also want to thank our hosts today, the Kingdom of Eswatini. In local language, they call them Emaswati Amahle. Beautiful people indeed. We are happy to be having them as part of the Lab Corp, and we continue to look forward to meeting all of you with time. Ladies and gentlemen, it's been a pleasurable 1 hour. Till we meet again, thank you. And before I go, I'm going to put on the screen a certificate. Yeah. If you would like to go to the ASLM Academy page and be able to download that certificate to acknowledge your presence. Thank you and goodbye from the Kingdom of Eswatini.
Thank you. Thank you very much.